Hi, my name is Hasan Ahmad, and I'm a third-year medical student at the University of Pennsylvania. Today, I'll be discussing our translational research efforts to objectively classify outcomes after lumbar spine surgery using smartphone-based accelerometry. The current standard of care for outcomes assessments after spine surgery are patient-reported outcome measures, or PROMs. These patient questionnaires, such as ODI or EQ5D, are surveys usually given to patients once preoperatively and once postoperatively to assess improvements in pain and functional ability. While they do collect valuable information on the patient's own interpretation of their postoperative recovery course, they are inherently subjective and thus open to recall bias. As in all realms of medicine, objective data is a true gold standard for driving clinical decision making. Our research aims to objectively measure patients' functional ability by leveraging data collected through smartphone accelerometry sensors. Most smartphones already passively collect this data, such as how many steps you take per day, although this information is not routinely available to physicians. In this pilot study, we retroactively extracted daily steps from 16 patients' smartphone data across a 2-year window, from 1 year preoperatively to 1 year postoperatively, in patients undergoing lumbar decompression surgery. Here we can see the raw steps taken per day, followed by normalizing and smoothing this time series. The last panel applies our data-driven algorithm to the patient, which automatically segregates the patient's time series into 5 discrete epochs: the patient's preoperative baseline, a period of acute functional decline prior to surgery, which could be due to an acute process such as disc herniation or an acute on chronic process such as exacerbation of spinal stenosis. The third epoch is the patient's expected postoperative recovery period, followed by their recovered state where the patient's activity is commensurate to or above baseline levels. And the fifth epoch is a possible period of secondary decline, such as in this patient's case of a reherniation of their disc. Across 16 patients, we found 4 distinct phenotypes of perioperative functional status. Some patients had a normal operative course with a recovery period indicating decreased physical activity due to postoperative pain and rehabilitation, followed by a long-term improvement in overall functional status, while other patients unfortunately did not experience sustained improvement in their physical activity after surgery. Initial presentations between patients were also different, with some patients presenting with an acute, sharp drop-off in activity, and other patients having a chronic waxing and waning functional status, likely reflecting a more chronic lumbar pathology. This breakdown in patient phenotypes was actually featured on the cover of the Red Journal this past May. To further investigate phenotypic differences in patients as categorized by this objective data, we constructed a classification algorithm to classify patient activity into 2 groups: 14 acutely presenting patients who received laminectomies, and 15 chronically presenting patients who received lumbar fusions. In our algorithm, a permissive threshold, which detects modest changes in physical activity, classified laminectomy patients with 100% accuracy and 100% sensitivity and specificity. However, this same threshold was not sensitive or accurate in detecting fusion patients. Using a different, stricter threshold, which is more attuned to chronically presenting patients, resulted in significantly greater accuracy and sensitivity in our classification. While this preliminary analysis still needs to be validated with a greater number of patients, it is clear that objective outcomes can be used to phenotype patient presentations and outcomes. This is a short summary of some of our work in this space. This is an exciting field, and there are many avenues we're still exploring, including using more advanced analytic methods such as machine learning and principal component analysis. We're also working on increasing our sample size by partnering with other academic institutions. Finally, I'd like to extend a thank you to our lab members, and especially to my research mentor, Dr. John Yoon, who has pioneered this work. I'd also like to thank the Department of Neurosurgery here at Penn and his leadership, including our chair, Dr. Yosher, and Dr. Welch, the director of the Spine Center at Pennsylvania Hospital. Pennsylvania Hospital was actually the first hospital in the US and was also home to the first operating room. And it's been an honor to have our lab continue building upon this 250-year legacy of excellence and innovation. Thank you.